Okay, let's talk about employing techniques to prevent epidural catheter failure. So our objectives are, we're going to discuss the risk factors and peripartum outcome of failed neuraxial anesthesia. We're going to discuss how good communication can help prevent epidural catheter failures. And we're going to discuss and employ rescue techniques, and we'll go over some algorithms that hopefully will help you in your practice. So what's the definition? There's multiple definitions of neuraxial analgesia failure, and it is a common problem. And one of the reasons is no matter what we've done, and all throughout the years, we've tried to decrease the incidence, but the incidence still remains around 10 to 15%. So that tells us that there's probably some unassociated factors, some factors that we've not known that we have yet to identify as causes. Nearly 1/4 or 25% of all epidural reactivations fail, and it can lead to problems with the patient, and it can also increase healthcare costs. Peach in 1998, he described failure as an epidural minor complication, and he defined it as failed or abandoned epidural insertion, a reinsertion, or inadequate analgesia. His incidence was 8.8%. Hess in 2001, he defined failure as greater or more than 3 episodes of breakthrough pain. So you can see this, we're getting all this like different definitions, and there's really no one definition that everyone's satisfied with. In 2004, Pan, he described it as lack of analgesia, intravascular placement, migration of the catheter tip, or a wet tap. He found his incidence to be 12%, which was similar to the same incidence that Hess had. Agram in 2009, he described it as a difficult insertion rate defined as 2 or more attempts, where Hess had 3 attempts. So the incidence he got was 8.6 to 10%. So if you look at all this, the definitions are definitely unclear, so we really need to come up with a better definition. A widely accepted definition is lack of analgesia after 45 minutes, so that's probably one of the criteria. So really, if you're looking at the literature, this should be all part of the definition. So it could be an accidental dural puncture, the need to replace the epidural catheter, or abandoning the technique to use another technique, or maternal dissatisfaction at the follow-up visit. So we definitely got a definition. So what are some of the factors that we know that are already out there? So there's patient-related and also procedure-related factors, and let's go over all of them. So the first one is a high body mass index. So we know if they're morbidly obese, it's much harder. And probably the main reason is that the anatomy is all different. So you probably will have an increased incidence of having a loss of resistance, and it's not in the correct space. Well, how about non-visible or palpable anatomical landmarks? Same type of reason. If you can't find the mid-place or mid-space, then it's going to be, or the midline, it's going to be much harder to place your epidural catheter. Also, a previous history of failed epidural, so that goes without saying too. So if someone's going to have a failed history, then probably doing it again, you're going to run into problems. Poor patient cooperation. So if they're like advanced labor, or they can't sit for you and they can't get in the proper position, it's going to be much more difficult to place that labor epidural catheter. Longer labors, most likely probably because the longer the labor, maybe with the epidural catheters in, it might work its way out. And it does migrate, as Dr. Riley said in the previous lecture. Pre-procedural pain. So if more pain, the harder to sit steady to get that epidural catheter. An incidence, how about breakthrough pain? So if they have breakthrough pain, maybe your epidural's not working, and poor communication skills. So pain is a subjective sign, so they're going to have to tell you if they're getting relief or not getting relief, so it's going to be much harder if you can't communicate with your patient. How about procedure-related risk factors? So the clinical inexperience of an anesthetist or anesthesiologist, you'll see this with repeated studies. When I go on to more of the studies in the lecture, you'll see that the clinical experience of the anesthetist really factors into it. The chosen method for loss of resistance, so you can do saline or air, and there's some data that shows if you're going to use air, sometimes you can cause an airspace and you may not get adequate diffusion of the local anesthetic in the epidural space, and that could be a reason. Epidural catheter design, the wire reinforced catheters are much better compared to the hardcore plastic, where the hardcore plastic is more likely to get into an epidural vein, and you can also more likely to get a one-sided block. A mono-orificial catheter, so if you just have a catheter with one orifice, it could potentially go up against some skin, and when you infuse the medication, it could actually block it. So there's some evidence out there that if you have multi-orifices, that it's better and you can get some spread, at least into the epidural space. And also catheter stiffness, of which we talked about earlier. There are some anatomical reasons, and I've not really, seen this, and but they talk about it theoretically. You could have the presence of a plica mediana dorsalis, so some tissue that basically prevents the infusion of the medication. So if you have this dorsalis tissue that sits out there, that if you infuse medication, it basically goes off to one side, and it could make it more difficult. And there's always the possibility, the rare possibility, that you might have a subdural block, which is definitely not an epidural block. So techniques, so this one slide is sort of things that you can do, and I'll show you more algorithms later in the talk. The sitting position is recommended by some, but it really doesn't matter. It really depends. You can either do in laying lateral or the sitting position. Me personally, I like to teach the residents to the sitting position because you can get your axes. So you get your x-axis and your y-axis, whereas if you're laying lateral, you can have rotation of the spinal column and it can make it more difficult, but really it just really depends on what you feel most comfortable. The sitting, like I said, and lying positions are acceptable. It is mandatory regardless that if you question whether the epidural blocks, the catheter's working, to really check the block level to make sure that is it lateral and are they really getting any level. So you can have breakthrough pain, and if you do, check the correct position. That's really important, and you have to confirm that the catheter is not migrated to one side or the other, or potentially it could be intrathecal. If you have a unilateral block, so one side's getting numb and not the other, there's a couple things you can do. Like I said, if you put too much in, if you thread it in too much, it can lay off to one side. So pulling the catheter back a centimeter or so, maybe you can get it more in the midline, and you'll get adequate diffusion to the right and to the left. Potentially, too, the patient could be just laying on one side, and she may have to switch positions, and that could help, too. If there's groin pain, maybe there's just not enough block, so you have to give a top-up dose. So regardless, a lot of these ones, errors and recommendations, you have to give a top-up dose. So if still complaining, you can just recite the epidural or do a CSC. And the literature does talk about that. If you've done an epidural and it's not working and you need to redo it, I personally like to do a CSC because I feel like I owe it to the mom to not have her go through the torture of another epidural and waiting another 20, 30 minutes and to see if it's not working. Whereas if you do a CSC, and at least with that intrathecal component, they get adequate analgesia and it's immediate. So here's the combined spinal. We talked about this at multiple talks today. So normally you give a low-dose spinal anesthetic, you thread your epidural catheter, and then you can run your typical epidural infusion. The advantages, there's multiple with CSC. It's a faster onset. You have better initial analgesia. You get a higher increase in maternal satisfaction, less motor block, less physician workload, and a less need for clinician boluses. And it takes about, the spinal part, you get an hour and a half, maybe 2 hours out of it before the block or the density tends to wear off. So there are concerns about an untested epidural catheter, but there's a lot of studies that if you do see CSF, you're probably in the right position. But theoretically, in a really morbidly obese patient that has a difficult airway, theoretically that catheter may be untested if you're not running infusion, and if there is a stat section, there is a possibility. And also, but the thing about CSC, the bad thing is that the time to detect a catheter failure can take longer for the CSE component because of the spinal. It takes time for that to wear off. So, and we did talk about this earlier, the CSE versus dural puncture epidural, or EVE, epidural volume extension, versus labor epidural analgesia. So that I personally do not use that, but they do talk about doing that. And basically you do the epidural catheter and you just puncture into the CSF, but you don't give a dose like you would for CSE. You just puncture it, and the studies have shown that you do have an increased block, and you have better maternal comfort and pain and analgesia. But there was a clinical trial by Chow et al., and he compared the three and basically came up with these conclusions that the analgesia was faster with the CSC, but the DPE, or epidural volume expansion, had fewer maternal and fetal side effects, because you can get fetal bradycardia with the CSC component, and you had less headaches, and there was no difference in analgesia when compared to the labor epidural anesthetic. So DPE showed improved block quality compared to the labor epidural, like faster onset, and it's something that you can do, and it may have something in between a CSE and the labor epidural. So in conclusion, DPE could be offered, and it could have a favorable risk-benefit ratio for initiation of labor epidural analgesia. So what are some techniques to prevent epidural catheter failure? It's really important to use the right dose at the right time and use the right drug. So that's real important to do that. You want to, like Dr. Riley said, you want to use less concentration. You don't want a total motor block, so it really depends on where you're at. If you're in advanced labor, you may want to use more of a concentrated local anesthetic to take care of the pain. Ideal administration mode is really, Dr. Riley did talk about the PEIB versus continuous epidural, and there is benefit, but there is a heavy debate as to whether PEIB is much better than PCEA. So the word's not out. Probably more studies need to be done to definitively say which one is better. And lidocaine is, if you're going to bolus, it's probably okay for labor, but you don't want to continuously use lidocaine. And the reason is that you can get more tachyphylaxis and you can get neurotoxicity. It is not recommended for labor analgesia. Sometimes you can use it just to test to see if your epidural catheter is working, but really it should be used, and if you're going to use multiple boluses of lidocaine, that it really should be used for cesarean delivery and not for labor analgesia. So other techniques, it's important to use opioids as adjuvants, and it's highly recommended because you can use less concentrated local anesthetic doses, you can achieve less of a motor block, which would theoretically mean less instrumental vaginal deliveries, and it does increase maternal satisfaction. You can use air and you can use fluid when you're doing the epidural technique, and it really depends on how you're taught and what is good. I personally like to use fluid because I like to see it and also feel when it goes in. The problem with using air a lot is that sometimes you can create these air pockets, and it's really hard, and it might be difficult for the local anesthetic to infuse, and sometimes you might end up with a spot where it just, that one section, you just can't get numb. But there's really no difference in the failure rate if you use loss of resistance to air or to fluid. So risk factors for a failed epidural, this was a study by Buckstein, who did a prospective trial on 414 parturients who received labor epidurals. He found an overall failure rate of 8.5%, so like I said, anywhere between 10 to 15% is probably the real rate. And women who had failed labor epidural analgesia had significantly more epidural attempts. They also had more dural punctures, and they also experienced more postpartum headaches. And significant variables that he found using multivariable logistic regression was if you had a fetal head station 1 centimeter above the spine, so -1 centimeters above, the use of oxytocin, and also the seniority of the anesthesiologist. So the experience of the anesthesiologist or the anesthetist or the provider is really significant as to whether it's going to be failed or not. The second stage duration and the operative vaginal delivery rate did not differ, so it didn't make a difference. So what about these risk factors? So higher fetal head station can be a problem because it's higher up. Maybe the baby's head is just not going to descend into the pelvis. And if you're using oxytocin, so it's almost like that, trying to pound a round head into a square. It's just really hard. It's not going to fit. So it can make matters different. So if you're high up, and it's just going to be harder, and maybe it's going to be inevitable that this patient might have to have a cesarean section. So the possible explanations, at least in the literature, Buckstein said, is that the greater pelvic resistance for a fetal head, and because of that, you're going to have more pain, and no matter what, if you just can't get that baby's head to descend and engage, that you're going to have pain regardless. So failure to convert labor epidurals for cesarean delivery. So the definition of conversion failure was unclear, so the definitions, they come out, they're all different, so really it probably would be good if we could decide on a definition of failure. But they found Bauer found that most defined conversion failure is the need for general anesthesia, or if you had to convert to another technique, and they found the epidural failure rate varies anywhere between 8.8 and 21%. And also, if you have a conversion failure and you can't use the epidural for cesarean delivery, there's other risk, and that you can get a high spinal. So if you dose the epidural and you go ahead and do a spinal, you can get a high spinal, general anesthesia, and also difficult airway. So there's also problems, and also fetal problems too. So Bauer, in his study, he did a meta-analysis of 13 trials that involved 8,000 women, and he looked at the reasons for failure to convert, and he defined failure as missing analgesia to at least a T6 level. He found that if he defined failure as if after 20 minutes you didn't have an adequate block given a top-up, and also if they complained of intraoperative pain during the cesarean delivery. And the 3 factors, so this is like a common theme here, that he found for conversion failure was an increased number of clinician and missed top-up. So the more top-up boluses that you had to give during labor could be a problem. The grade of the urgency, so if it's like a stat section and you dose up that epidural, you might not have enough time to get adequate analgesia and anesthesia. And also the anesthetic care provided by non-obstetric anesthetists or anesthesiologists. So there's another recurring theme about the experience of the OB anesthesia provider. So the choice, does a conversion failure sometimes it depends on the urgency of the cesarean delivery. So likely lidocaine's good, 3% chloroprocaine would be good. Spinal, what they recommend, if you do dose that epidural and you're going to do a spinal, you need to be careful. And if there's 30 minutes or less, just be careful because you can get a high spinal. And in fact, in the SCORE project by Dr. D'Angelo said that 50% of high spinal blocks was a result of the failed epidural conversion. So you need to be careful when you do it. Typically, you at least like to wait 30 minutes before you do a spinal, but for me, I personally do like to give a spinal, and I'll do it before 30 minutes, or I'll give a top-up dose, but I'll just be very careful, and one of the reasons is because you can get a high spinal, and if I do pull the catheter, you dose the epidural catheter, and it's not working, I'll pull it and I'll give a spinal, but you just give the dose that you need. So just give the minimal dose that you feel that you need to do a cesarean delivery. And what I'll do is sometimes before laying her back really quick, I'll sit her up a little bit. That way I won't get a high spread, and then I'll be more apt to give vasopressors too, to make sure that I'll keep her pressure up. So, and then the other thing too that you have to worry about is if you do dose that epidural catheter and there's a partial block, that you can get a spinal cord injury if you're going to do a spinal for that cesarean delivery. One thing is if they are morbidly obese and you do get that spinal, maybe go ahead and thread a spinal intrathecal catheter so that you can dose it, so you'll have a decreased risk of local anesthesia toxicity, and you'll have a decreased risk too of also of a high spinal. If that all else fails, then you have to do a sedation and with supplemental adjuvants. And you just need to be careful. So typically you can give ketamine, fentanyl, propofol, nitrous oxide, anything that you can do to help her get through if you have a partial block. What I tend to do is just basically monitor what I give based on the O2 saturation and the respiratory rate, because when you give these supplemental adjuvants, you can get aspiration, hallucinations, intraoperative pain, and all kinds of problems. So really the treatment needs to be individualized when you do give those supplemental IV medications. So general anesthesia, it's prompt conversion, and maybe it's based for fetal reasons, you need to go. The Royal College of Anesthetists recommend that the general anesthesia for cesarean delivery should be less than 3%. And in fact, they specifically say 1% for a scheduled cesarean delivery and less than 5% for emergency cesarean delivery. We talked about earlier, remifentanil is a good drug to use because it's quick on and quick off. And if you're going to do a rapid sequence induction, you have to do that because you worry about aspiration, propofol and rocuronium are the best, should be the standard. So this is just the algorithm, and I'll just show you. This is for labor analgesia, and if you start here, so labor analgesia, and you're just using the epidural catheter. So if you have a failure and there's no analgesia, you basically just either need to redo the epidural catheter, or you can do a CSE. I personally like to do a CSE just because I feel like I failed the mom the first time. So doing a CSE, you'll get a quicker analgesia for her. Now, here's the complicated side, is when you have breakthrough pain. No matter what, you have to give a top-up, but first you need to aspirate first to make sure that the catheter hasn't migrated. And if you do have a lateralized block, then you could have a plica media dorsalis, so you have to worry about that. But you maybe layer on that side, give her a concentrated dose, so hopefully you can get that numb on that side. If you have a low-level block, then you're just going to have to give more of a bolus. And if you have a patchy block, you should consider if it's subdural or not, or you think of maybe just redoing it, do a spinal or a CSC. Now this is just, the next one is just for a cesarean section, and likewise, if you have no analgesia, that makes it easy. So you can do a CSE, maybe if they're morbidly obese, so you're doing that cesarean delivery, and if that spinal wears off, you can at least dose through the epidural catheter, or you can do a spinal. So I sort of like to stay on this side, which is nice. If you do a CSE and you decide not to dose intrathecally, then you can use an epidural top-up. This is the bad side here, so you do an epidural top-up with 2% lidocaine. This is probably not a good idea with ropivacaine. It takes longer, so maybe chloroprocaine is what you want to use. And then you come here, so epidural failure, so you have the complete failure, you'll have to go to the GA, or if there's a partial failure with your epidural top-up, then you have to go to the IV medications. So it's pretty straightforward, and it works. So how about reactivation for a postpartum tubal ligation? So same type of deal. So remember we said is that the experience of the anesthetist, so that has something to do with it. So I'm tending to think it's going to pop up. So Powell, he looked at specific risk factors for failure for postpartum tubal, and what he did is he got 100 patients, and how he defined it is that the epidural catheter was still within 2 centimeters of initial placement, and he defined failure as any patient that did not achieve a T6 level to pinprick on the skin prick, and had a perceived pain that required administration or an IV. So if you had to give a supplemental anesthetic intravenously or altered your technique, then that was defined as a failure, and also if you required conversion to a general anesthetic. And the overall success rate that he found by reactivating the epidural was 78%, and he found that risk factors for failed, for postpartum tubal, poor patient satisfaction, so it wasn't working well, increased time to reactivation, so that sort of makes sense. So if there's a long time, maybe 18 hours, 24 hours before they do that tubal, maybe that catheter's migrating, so that could be a problem. And also the need for top-ups. So what I do is when I see a patient and they really want to, we're going to do a postpartum tubal, and it's the morning, and they want to, and I'm like, I just go right to the patient and say, does this catheter ever work? And they're like, well, yeah, I did, or no, they've been bolusing all night. That's all those top-ups. That's like a red flag to me that that's not working, so I'd rather pull that epidural catheter and do a spinal and make sure that it works. And also, if you look at, and poor, like I said, so for those reasons, you can talk and hopefully work it out. Now, sometimes I'll get a mom who really wants that labor epidural, and she might even like, oh, it took forever to get that catheter, can you please use it? And it's almost like they'll get really upset and cry and melt down if I pull that epidural catheter and do a spinal. And I'll just tell them, look, okay, so I'll work with you, we'll dose the epidural, and we'll do what we can to get you through it, and we don't have to do the spinal. So really individualize and work with the patient. When they did find that there was no correlation with the body mass index, there was no correlation with loss of resistance, and there was also no correlation with failure to reactivate. So in conclusion, recognize risk factors for epidural failure include prolonged labors, because you can have migration, previous history of epidural failure, repeated top-ups. If you're going in there and just continually giving top-ups, it's probably not working. Also, the clinical experience of the anesthetist and your choice of neuraxial technique has a lot to do with it. A labor epidural, doing a CSE, so if you can individualize, that will help. And also, good communication is really important and crucial. So you work with the nurses, you work with the patients, and you can jump on it quickly before it gets to be a problem. And that's it. Thank you.